Well, good morning, everyone, and welcome to hsa-bc's webinar, Navigating Safe Supply. My name is Sarah Kift, and I'm your host for today. I've worked in the frontline nonprofit sector for over 15 years, including in Vancouver's downtown east side at Carnegie Community Centre, and I develop and host webinars for hsa-bc. I also live, work, and raise my family on the traditional and unceded territory of the Kakite First Nation, and I do that with gratitude and a continued awareness of the need for advocacy and support of Indigenous issues. So when you're using the question section, that's me who you'll be chatting to, and I'll do my best to share your questions and comments with Corey as they come up. We really welcome your input as we discuss things today, as this is an ongoing process. It's a new thing. And so there's going to be a lot of shifts and changes and questions, and we really welcome those. All right, so we have a quick poll here today. And this is just for Corey and I to get a sense of where you are and where you're coming from so we can think through our content that way. So what's your role in your organization? Are you a supervisor or a manager? Maybe you're a frontline or outreach worker. Maybe you're in support staff. Maybe you're a board member or an ED. And if you chose other, just type that in and let me know what that means for you. I know, having worked in frontline and nonprofit work for many years, that oftentimes it's all of the above, right? And a lot of our work is even outside of our job description. So yeah, let me know if we've got some interesting roles on the line today. I think this is the very first time that this has ever happened. So 100% of the people on the line today are frontline and outreach workers. That's mind-blowing. Thank you for being here and taking time away from being out there doing the work. We really appreciate your presence today. All right, this is always my favorite part. I get to introduce our amazing instructors to you. So this is Corey Ranger, and he started his nursing career facilitating a bloodborne pathogens program in the Edmonton downtown core. And since that time, he has worked in harm reduction in downtown Calgary. He's worked in HIV programming in rural Alberta, as well as the Take Home Naloxone project and supervised consumption services in Medicine Hat. Corey is highly driven and passionate about ethical and evidence-based approaches to public health problems. He has a wealth of experience in both formal and informal education, having acted as an instructor and a coordinator for the practical nursing program at Medicine Hat College. And he has been working in encampments and supervised care sites since before the pandemic began. And he has responded to many critical emergencies and overdoses, as well as training others to respond safely with care and compassion, using his practical nursing skills and passion for universal quality care for everyone. He has worked with housing providers in Victoria and the government to manage safe sites in temporary housing and hotels. And most recently, he's taken on the leadership role of clinical nurse coordinator for AIDS Vancouver Island and Solid to manage their safe supply project. He's also working with various organizations across the province to map out the process for safe supply, to advocate for change, and to raise awareness around the issues. So Corey, we're very grateful that you are here today with us. Thank you for being here.
Thank you so much for having me, and for such a great introduction. I am very appreciative to be here today. I'm very appreciative for the opportunity to speak to you all and to talk about safe supply. I just want to acknowledge, as Sarah pointed out, how amazing it is that there's so many frontline people on today's call. If you're all here, I hope that there's other people working right now, but it's so great because a lot of you have been doing tireless work. You've been really shouldering a lot of the load of this dual healthcare crisis that we're experiencing here in British Columbia, that being the global pandemic and the opioid overdose crisis. So thank you to all of you and the work that you do on a daily basis. This has been a really challenging time for sure, but we're getting there and we're making good strides because of people like you. So thank you again. I don't want to spend any more time talking about myself because Sarah just read off my LinkedIn profile, I'm pretty sure. But I also want to thank hsa-bc for continuing to facilitate these info sessions and these webinars. I hope you all find this information useful. Today, the goal really is to have a good conversation about safe supply, where we're at and where we need to go. But most importantly, what can you do as frontline workers in order to facilitate access to safe supply for your clients? I encourage any kind of questions or comments or concerns. This is a new subject for a lot of people. And so it's natural that we have our own ideas and stories about what safe supply is. And hopefully today we can debunk some of those myths about safe supply and we can develop a better mutual understanding of it. I want to start off, of course, by acknowledging that colonization, racism, discrimination, and the institutional oppressors that continue to permeate in our society have far-reaching impacts to Indigenous people who call this land home. A land acknowledgement is not enough to rectify some of the tremendous harms that have been caused by colonization, but it is a humble approach to agreeing to continue to acknowledge those harms and to take concerted steps forward to improve some of the tremendous issues that we've created. I recently have tried to challenge myself in how I do a land acknowledgement, but also about what I do on the land that I live on. It's no longer enough to simply do a land acknowledgement. We can acknowledge it, but we need to say, now what are we going to do about it? And it's really important to acknowledge that colonization still exists today. When we see the impacts of the overdose crisis on Indigenous First Nations and Métis peoples, when we see the impacts of poverty and homelessness, colonization actually is alive and well, and we need to continue to try and break down this system that's been created and enforced for so long. I recently attended a webinar that was hosted entirely by an Indigenous peer organization, and they did their land acknowledgements, and they actually put people on the spot and say, like, do your land acknowledgement, but tell me specifically why you're grateful to be on this land. And it made me really uncomfortable at first because I didn't know what I was going to say. And so all I ended up saying is I acknowledge that I have so much to learn and that I have not even scratched the surface of what I need to learn in order to be as genuine as I should be when I'm doing these. And so that's a goal of mine. So after that long preamble, what I will say is I'd like to acknowledge with respect the Lekwungen speaking people whose relationship with the land has gone on for hundreds of years, as well as the Songhees, Esquimalt, and Wasanic peoples. And I've recently broadened it out because it turns out that I'm also on the Malahat territory as well. And I am very appreciative and grateful to be on this land. I also want to acknowledge that today we're going to be talking about some subjects that can potentially bring up emotions for people. The topic of overdose, of addiction, substance use, poverty, and death, and despair. They're things that can bring up a lot of trauma for people. As frontline workers, you've seen the harms that have been generated through overdose. And so I just want to let you all know that some of these subjects can be a little bit triggering. We talk about stigma, we talk about criminalization and prohibition. And so if you are feeling some of these emotions, please know that this is a safe place. If you have a question to ask, if you need to step away, don't hesitate to do so. I also want to start off by telling a little bit about my story and how I got here, as well as a little bit about the overdose crisis and how it's been on the rise. So when I first came back to British Columbia, I actually was a team lead for a medical detox site in Victoria, and I quickly realized that I did not want to work in that type of field. There was a lot of issues that I had seen firsthand where people weren't being given the supports that they needed, quite often being set up to fail, and a lot of harms being generated in that process. I was fortunate because I transitioned right away to a project manager job, and for about 8 months, I was working exclusively not on the front lines, and I had not really been well connected to folks who were on the ground here on the island. And then COVID happened, and it was very serendipitous how I got pulled into this. Sarah actually invited me to do a webinar on COVID preparedness. And as I started to do the research about it, I realized just how unprepared we were and that there was a lot of potential issues that were coming. And so I took a leave of absence from my project management position in order to join folks on the front lines in the homeless encampments in Topaz Park and Pandora here in Victoria, and to support overdose prevention services in developing outbreak protocols. That snowballed into a place where now I am a clinical nurse coordinator for developing new safe supply delivery models here in Victoria, working in concert with peers, people with lived and living experience. And so it's definitely been a wild 2020. Now, in terms of overdose, in British Columbia, the overdose crisis and the public health emergency that has been declared because of the overdose crisis has been going on for around 5 years. This isn't something new to us, but those of us who were on the ground and those of us who were paying attention to the trends realized that with COVID coming around and all of these precautions and recommendations from public health authorities encouraging people to isolate, to social distance, to self-quarantine if they're symptomatic, that it spelled a potential disaster for people who were at risk for overdose. And what we saw was exactly what we predicted. In April, we saw an increase in overdoses, and by May, we had really noticed that COVID itself, yes, it's concerning, but overdose continued to be the most significant risk for people in British Columbia, especially those who use substances and experience poverty. So these two infographics here show a little bit of a timeline of where we've gone comparing coronavirus to overdose in British Columbia. The one on the left, A Tale of Two Crises, was something that I made with an individual from the BC Centre on Substance Use, and that was in April. And so by April, we had 377 overdose deaths, but only 161 COVID-related deaths. And so over double the amount of overdose deaths compared to COVID. And it really dawned on us that our decision makers and our government were not prioritizing the overdose crisis in the same way that they were prioritizing the COVID crisis. By May, things had gotten even worse. In May, we broke a record for single amount of overdose deaths in a 1 month. So in May of 2020, we had 170 overdose deaths. Compared to the 167 COVID-related deaths that we had for the whole year. In total, pardon me, we had 547 overdose deaths by May compared to the 167. So what that tells us is that you're actually around 4 times more likely to die by overdose than by COVID in British Columbia. And I'll just let that stat sink in for a minute. Now, why is this happening? Why have overdose numbers increased in such a dramatic fashion? Well, there's a number of reasons for that. First and foremost, we had supply side problems. And what that means is we had border restrictions, we had disruptions in the illicit trade from dealer to distributor, which created inconsistencies in the market. We also saw a significant increase in the level of contamination of the drugs that were available on the streets. I work very closely with a group of drug testers, and they take samples from people. Sometimes they bring them in, sometimes it's after an overdose happens. We want to see what could potentially be in it. Leading up to the overdose crisis, leading up to the surge in overdoses, what we really thought we were going to see was an increase in benzodiazepines being mixed into the illicit drug supply. We thought we were going to see less fentanyl on the streets, but more benzos, like Azidalam or Xanax or Ativan or Valium. But what we actually saw was both fentanyl and benzodiazepines increased in concentration. We had one overdose that we responded to when we tested the drug sample afterwards. And that particular sample contained 24% fentanyl. And for your reference, pre-pandemic, before the pandemic started, the average concentration of fentanyl in the street drug supply was around 5 to 8%. Wow. And so there was, 3 to 4 times more concentration of fentanyl in that drug. Since then, we've heard of samples containing up to 50% fentanyl. And so it's truly become an incredibly dangerous time for people who use illicit substances. And another reason why that's happened, why people have gotten to be at an increased state of risk, is because there's been an increase in isolation for people who use substances. We've seen isolation happen to people who live at home who are at risk for overdose. around 80% of people who die by overdose actually die in their homes. And so we've been telling people they have to stay inside, they have to minimize their contact with others, and they're still at risk of dying from overdose, but now they don't have their support system available to revive them, to be with them, and to support them. We've also seen a lot of controlled movements of people who experience homelessness and poverty. We've seen this through the establishment of encampments in the downtown east side and in Victoria, and then the subsequent decampment process where some people were brought into hotels and some people were pushed out into more peripheral areas. Every time you displace a person, you increase their risk for overdose because you push them to an area that's harder to get to. You push them to hiding and to using alone, which in turn means that there's nobody there to support them if they do experience an overdose. We also saw people who were supported well in their communities when they were in homeless encampments. Not that the camps themselves were great or that they were perfect, but they had their street family with them. And within days of being brought into a hotel, they passed away because of overdose. I can't tell you the number of times now where I start my shift and I find out about another person who's died because of overdose. I can't tell you the number of overdoses that I've responded to during this 2020 year, which truly feels like it's already been a couple of years long. So naturally, we have to do something about this. We have to do something. We have to find out what are effective strategies in order to support people who are at risk for overdose. And we've been calling for safe supply for quite some time, but it took a pandemic in order to see decision makers really move forward on it. This next graphic here comes from Nouvelle News and was brought to me by Guy Filicella, who is an advocate in Vancouver who works with the federal and provincial government in order to develop these types of guidelines on safe supply. It's a comparison of the opioid crisis and COVID-19 up to date. And so in the first 6 months now of 2020, there's been 725 deaths related to opioid overdose. And the opioid crisis in BC continues to get worse. I said in May we had 170 deaths. In June we had 175 and broke that monthly record once again. And so the risk continues to rise, and it's across the board. It's across the province. People in the north are dying by overdose. People on the island are dying by overdose. And we've seen a lot of people who have truly been impacted by this. So now that we've done that little preamble and set the table, we're going to talk about one of the strategies needed to reduce the harms of overdose and the illicit toxic drug supply that's available right now. So we're going to talk about reviewing the basics of safe supply. What is it and what are the benefits of it? We're going to talk about what the current issues with safe supply, especially related to access. I'm sure a number of you have tried to help support a client or a community member to gain access to safe supply, and you can see firsthand how the system is quite fragmented, how it's inconsistent from a prescriber to prescriber basis, how the clients aren't really getting the access that they need, or maybe they're getting services that are being tied on to it that aren't appropriate for them. One of the big issues that I'll acknowledge right away is that safe supply currently is being viewed through an addiction medicine model, and it really needs to be viewed through a harm reduction lens. And we'll talk a little bit more about that as we continue through the presentation. And then I'm going to take you a little bit through the current risk mitigation guidelines and remind everyone that they are just guidelines. They are not set in stone. Then we'll talk about what each and every one of you can do, regardless of what your role in the community is, so that you can work within the current legal framework and guidelines to help someone access safe supply. As Sarah alluded to, I put together an infographic that is kind of a pathway as a frontline worker that you can follow in order to support someone getting access to safe supply, but also doing some of those other really valuable pieces around getting someone access to safe supply. That too is a working document. And I had a really great time, like Sarah said, where researchers from the BCCSU and researchers from the University of British Columbia all chimed in, and we were talking about things that we could add to the infographic in order to make it improved. So as we continue to build it out, I'll continue to send updates to Sarah. And then we're going to finish up by talking about some of the new and emerging models for safe supply, including one of my favorite topics to finish on, which is advocacy and what we can do to make the changes that are necessary in order to make safe supply more effective at reducing the harms of overdose. So let's talk first and foremost about what is safe supply, and we won't make any assumptions about your knowledge today. Safe supply goes by a few different names. Here on the island, it's being exclusively referred to as PPRM, or Pandemic Prescribing Risk Mitigation. There's some issues with that, and the reason is because it's been framed exclusively around the global pandemic. And so what that means is it has some connotations that maybe this won't be something that's permanent. And we really need to make sure that when COVID-19 is no longer a thing, that safe supply is still here. Because when the pandemic ends, overdoses will continue to occur and the risk will continue to be there. And we can't lose some of the important progress that we've made during these really trying times. Safe supply itself is the prescription and or distribution of pharmaceutical alternatives to the illicit and toxic drug supply. This isn't really a novel concept because iterations of it have existed in Switzerland and the UK for quite some time. There are heroin-assisted therapy programs in the UK and in Switzerland. Some of them no longer exist anymore, but they've been showing positive impacts for people who are at most risk for overdose and other negative health consequences related to illicit substance use. It also exists in small little microcosms in Canada. In Ontario, there's a doctor by the name of Andrea Sereda and a group who have been prescribing safe supply to their clients out of their clinic, despite not being supported by a legal framework. And we've also seen programs like Crosstown Clinic in British Columbia with their IOT program, injectable opioid agonist therapy, which is a much more clinical version of safe supply. It's not quite the harm reduction version of safe supply, but it's already been there for some time. And Crosstown has gone through two very extensive pilot studies, the Salome and the Naomi trials, and they actually were able to continue operation after those trials despite not being supported by a legal framework, because when the federal government at the time tried to close them down, they took them to the Supreme Court and it was noted that these are essential life-saving services that shouldn't be taken away. So it's already existed a little bit, is what I'm trying to say there. Safe supply, by definition, is about meeting people's needs and by providing as close as possible to what they prefer to use without the massive concentrations of fentanyls and benzodiazepines lurking about and inflicting harm. We've done safe supply before. When alcohol prohibition was a thing in Canada, it was very brief for the general population, but actually alcohol prohibition existed for a long time for Indigenous people here in this country. And that just speaks more to some of the systemic racism in the war on drugs. And when alcohol prohibition really took hold in the United States, what they learned very quickly was that prohibition led to an increase in organized crime. It also led to an increase in harms related to toxic supplies of alcohol. And eventually a bunch of people went blind and got sick and died because of a toxic wood grain supply of alcohol. And so what they decided is, instead of trying to control the supply of it, they were going to regulate it. And they were going to provide safe versions of that drug, because alcohol is also a drug. And they were going to provide them out of establishments that had to have standards, so that if you drank too much, they would make sure that you got home, take away your keys if you were going to drink and drive, practicing harm reduction. And so safe supply has already been trialed once, and it's been quite successful compared to the alternative, which is to prohibit a substance. It is a direct contradiction to the supply side war on drugs, which has been an absolute failure in preventing drug use. and in slowing the drug trade. This graphic here comes from Filter magazine, and it's about the iron law of prohibition. And what this essentially tells us is that the more we crack down on the illicit drug supply, the more we try to tighten up on enforcement and view substance use through the enforcement lens, the more we actually increase the potency and the risks and the contamination of the substances that we are trying to prohibit. So the examples here is that when alcohol is prohibited, it moves to spirits and then quickly to moonshine. When cannabis is prohibited, then you get the high concentrations of cannabis followed by synthetic cannabinoids. Same with cocoa leaf and turning into powdered cocaine and then to crack, opium to heroin and then fentanyl and carfentanil, and ephedra to amphetamines to methamphetamines. And so what you can see here is a pretty telltale sign that the more we crack down on a drug, the more risks we actually create for people who are using those substances. And substance use has existed for a very long time. People have been taking mood-altering substances for thousands of years, and no matter what we do, that likely will not change. And so it's more important that we find ways to support people in their substance use than it is to try and continue doing something that has failed miserably for decades. As an aside, the war on drugs has also disproportionately impacted Indigenous people and people of color, and it has been a tool of the government in order to control such populations. And so that's another reason why safe supply is not only a good mitigation factor for overdose right now, but it's also the next necessary step so that we can eliminate some of those oppressive factors. Now, why would we do safe supply? Well, there's a lot of reasons. There's a lot of things that benefit people when we engage in providing a safe supply and an alternative to the illicit drug market. When we provide a pharmaceutical alternative, of course, the most important thing to us right now is that there's less overdose. People's drugs aren't contaminated with fentanyl. They're not contaminated with carfentanil. They're not contaminated with xylazine, which was a drug that we found in Victoria during one of the worst weeks for overdose in a long time. It happens to be an animal sedative that is toxic to humans. There's also less police intervention. If we're providing a legal substance for people to use, then they're less likely to be accosted by the police. They're less likely to be criminalized. There's less harms of them having to go to jail or forced into detox. And there's also less money spent on law enforcement, which happens to be one of the most costly initiatives in any government. There's also more balance that people experience. And this is some of the intangible things about safe supply that when you talk to people who are big into evidence, they can't really get behind because you can't quantify it very well. But I remember one of the first couple that we got onto safe supply, and the week leading up to getting them on safe supply, both of them had had 2 overdoses. Their tent had been robbed several times, and they were in constant chaos and just in a lot of anxiety, in a state of panic, that fight or flight response. And then we got them onto safe supply. We figured out how to get the drugs delivered to them by pharmacy in the encampments, and it was just incredible to see the following week. They were out, they were cleaning up their campsite. He was talking to me about how he didn't have to worry about picking bottles to find money in order to feed his substance use, and they just reported that they felt more stable. And that's hard to quantify, but it's so critical, because when people feel supported in accessing their basic needs, and to many of their substance use is their basic need, then they can start to worry about other things. Nobody's really worried about getting access to housing if you don't know what your next 10 minutes looks like, because you need to find a way to get some money so that you can not go through withdrawal. There's also less COVID-19 risk. So when we provide people with a safe supply, then they're not out hustling all day in order to get access to their drugs. Then they're not interacting with dealers and multiple points of contact where transmission can occur. This is actually one of the main reasons why safe supply was successfully, and I'm putting successfully in air quotes, but why it's successfully rolled out in British Columbia, is because it was tacked on to the increased risk for COVID-19 during this time. It's also cost effective. When you decrease overdose, police interventions, interactions, and disease transmission, you save money. You save money for the healthcare system, you save money for taxpayers, and that's important to quite a few people. It's not necessarily my main thrust of why we're doing this, but it's important that people know not only is this the ethical thing to do, the evidence-based thing to do, but it's also the cost-effective thing to do. Safe Supply also increases access to other services. Much like every other harm reduction service, when you meet people where they're at and you meet their immediate needs and you act in a client-centered way, that means what are your priorities and how can I support you, then people will come back to you and you'll redevelop trust that's been broken with the healthcare system, and you can help move them along the continuum of care in case there's something else that they need. There's been a number of people that we've helped get access to Safe Supply, and the next step was that they wanted to see the doctor to talk about some of their other health needs. They didn't feel judged, they didn't feel stigmatized, they were comfortable talking about their substance use history, and so they went and talked to doctors, and now they have increased access to all of the other services that they are deserving of. There's also less stigma when we provide a safe and regulated supply, then we remove the criminal element from it, which reduces the stigma and discrimination that people who use drugs often experience. There's less withdrawal, and it's important to acknowledge that withdrawal is really concerning for a number of reasons. When people are withdrawing from opioids and they're experiencing that dope sickness, they want to use, but their tolerance is also dropped. That means that they're an increased risk for overdose. People who are withdrawing from alcohol are at a huge risk for something called delirium tremens, and they can experience seizures, and we saw that in the homeless encampments in Victoria. People didn't have regular access to their finances or their ability to acquire finances, and people also didn't have access to purchasing alcohol for a little while, and so we actually had people who were having seizures in the parks, and Safe Supply does also include alcohol. And there are quite a few managed alcohol programs that have been rolled out here in Victoria and elsewhere in British Columbia. They too are not where they should be. They need to be improved. They need to be lower barrier, lower threshold, and more based off of the consultation of people who are actually accessing those services. But there has been progress made. And lastly, Safe Supply is a gateway to change, and not from the individual standpoint, but from a system standpoint. Decriminalization is the next natural step in this process, but we can't just get there overnight. But by making concerted strides towards a safe supply and then revising those guidelines so that they're more inclusive and lower barrier means we're getting a step closer to decriminalizing people who use drugs, which is something that we have needed for a very long time. And I'll talk about some of the news that has come out from the province related to Premier John Horgan's request to decriminalize people who use substances. This graphic on the right is directly from the BC Centre from Substance Use, BC Centre on Substance Use, and it just confirms that these are the risks that Safe Supply is intended to reduce during this dual healthcare crisis. I also believe I made this available. It'll be included in the handout section of the hsa-bc website, right, Sarah?
Yeah, that's correct. I think it's up there now, but we'll double check. I just want to
why
say,
isn't it working? Oh, go on.
That was like a download of truth to power. And I know it was a lot of information for me to take in. And I had heard of how enforcement leads to harder drugs, but that graphic was particularly mind-blowing. So I just want to say to everybody on the line, if this is all new to you, it's okay to just take a deep breath and take it in, because Corey just gave us a masterful summary of why Safe Supply is important and good, and hit all the arguments that people make against it.
It's quite funny because
yeah.
I left those two slides, like I usually have notes, and I left those two slides blank, and then I wrote in my notes, just talk. And then whenever I do that, it's either really hit or miss. I either hit all of the important pieces, or it ends up being a big rambling, and I rarely know the difference. So I'm happy that was a good explanation for everyone, but also acknowledge what Sarah said, that it is a lot of information and it is very new to people. So you're not expected to be an expert in this. This is an intro to safe supply and what can we do in the here and now, but not an expectation for everyone to walk away as an expert.
And I'd really encourage you to take a look at the handout, the PDF of the PowerPoint, because then you can go back, especially to that previous slide and the one before, and really think through your own reasoning and how it stacks up against those 9 reasons for safe supply. So
yeah. Now, unfortunately, safe supply isn't working right now. It's yet to hit the mark when it comes to meeting the needs of people who use drugs, and there is a number of reasons why it isn't working the way that it should. First and foremost, we're not giving people the right type of drugs. The guidelines currently from the BC Centre of Substance Use has a very myopic kind of menu of drugs that prescribers can provide. And for opioids in particular, it's Dilaudid or Mesalon. And that's not what people are using. And there's a big call right now for prescription heroin or diacetylmorphine to be included in the list of drugs. That's what was used in Switzerland and the UK. That's what's also used at Crosstown Clinic here in Vancouver. But the problem is that there's no manufacturing of diacetylmorphine in Canada. And the ability to try to import it on such a massive scale is A, incredibly costly, and B, wrought with all kinds of challenges due to the legalities of importing legal medical heroin. We also haven't been providing people with the correct dosage. Decision makers often downplay or show their naivety when they guess how much a person who uses drugs actually has the tolerance to take. We see this even in hospitals when people who use drugs present in the emergency department and they've got a fracture or a broken bone or some kind of injury that requires pain management, and the doctor will prescribe them 2 milligrams of IV morphine. And that's not even a high enough threshold to even reduce the pain because people are taking way more of that on the streets. And so again, the guidelines are a little too narrow and limited in what kind of dosages we can provide. Another reason is because we haven't done great enough consultation with people who use drugs. We haven't done a good enough job finding out what would work best for them and then trying to develop our model after that. The program that I am the clinical coordinator for, the SAFER project here in Victoria, the very first thing that we're doing is a series of engagement sessions with people who use drugs, who live in hotels, who live on the streets, who work in the sex trade, and we're finding out what it is exactly that they need in order to access safe supply in a safe and effective manner. Part of the problem too, as I've alluded to, is that it's being delivered through an addictions medicine model. So it's very much being tied to opioid agonist therapy or people's methadone and Suboxone. And so a lot of people are only prescribed their Dilaudid if they also agree to go on methadone. That smells a bit like coercion, and it's not what everybody wants. Not everybody wants to go on daily methadone. And so it reduces the likelihood that people will actually follow through and access that medication. There's still all kinds of concerns where if people miss doses, then they're cut off, having to require people to do a urine drug screen to prove that they actually have fentanyl in their system before prescribing. All of these potential barriers and checks and balances, each one that a person passes through means that they're less and less likely to be able to access the medications that they need. There's been some unintentional prescriber gatekeeping as well. And I work with a ton of really great doctors who don't want to be gatekeepers in this situation. I work with doctors on the Victoria Inner City COVID response team. I work with doctors for the Kool-Aid Mobile Inner City outreach team, and quite a few of them understand the purpose and want to support people, but all of the responsibility has been shifted onto them. And so there's risk aversion. People are afraid because this is such a new service. They don't want to prescribe something that could potentially increase risk, even though we know that it doesn't increase people's risks. The new coroner's report that came out last week from British Columbia actually showed that in all of the increases in overdose deaths, safe supply has not been a factor. So people who are dying by overdose right now are not people who are being prescribed Dilaudid. It is still the illicit fentanyl market that is killing people in droves. And so a little bit of that risk aversion is unfounded. But if you think about it a little more closely, if I'm a prescriber and Sarah is my patient, and Sarah goes out and she purchases some illicit fentanyl and she overdoses and dies, that's horrible. It's a tragedy. It's a reflection of the harms of the war on drugs. But if I prescribe Sarah Dilaudid and then she goes and uses Dilaudid and fentanyl and she passes away, her death is tied to my prescription. And so there are physicians who are concerned about what this means and how they can support people without inadvertently increasing risk. There remains to be some ideological problems. There are doctors who still will simply say that they don't believe in safe supply, and that's unfortunate because this isn't about beliefs. Safe supply is not Santa Claus. It's actually an evidence-based approach to keeping people safe during an incredibly high-risk time. There also hasn't been very much consideration for people who smoke their drugs. Actually, right now, the majority of people who are dying by overdose are people who smoke their drugs. That's been the highest cohort of overdose deaths in British Columbia. But safe supply in its current format and with the drugs that are available, those drugs aren't able to be smoked. So if someone comes to a prescriber and says, I smoke 2 to 3 points of heroin a day, and the doctor prescribes them Dilaudid as a safe supply, that's not actually for that patient because that's not that they can't smoke that. And so we really haven't taken a good enough, broad enough look at what people need. There are drugs out there that can be smoked, but they haven't been included in the risk mitigation guidelines from the BC Centre on Substance Use. As I've said, there's still too high barriers for access, daily dispensing, cutoffs, all of those things still exist, and that's another part of what the SAFER project is trying to work on. We're creating a nurse peer-led model where we can go and meet people where they're at. They can connect with a peer and a nurse, and the prescriber becomes someone who provides medical oversight but isn't involved in the daily gatekeeping because they really want to step away from this and make sure that they can support its delivery through a harm reduction lens. And then, of course, there has been really poor access for people who live in rural and remote areas. Really, really poor access. The BCCSU amended their risk mitigation guidelines, and it's called version 1.5 now. Version 2 is supposed to be coming out soon-ish, which is really exciting because it's supposed to deal with some of the issues I've described. But in version 1.5, they added a quarter of a page for rural and remote considerations. And essentially all it said was, try talking to your family doctor, and if you can't access it that way, we're sorry. And that's really not adequate because people in rural and remote areas are in even higher risk because they have nobody around to support them.
I'm sure that some of you on the line can identify with this. I know there's some people here who work in other parts of BC than the Lower Mainland. And so there's an added layer to get the services that your clients need, even without safe supply.
Yeah, and I mean, I'm sure people who live in those areas are just like, when they see some of these things come out, they must think to themselves like, oh, good, another thing for Vancouver. Or, you know, what we've really noticed is that people who have access to safe supply are the people who are most well connected to teams already. They have an outreach team in the community, they have a regular prescriber, or they're people who are already attached to some form of housing, whether it is supportive housing environment or it's the temporary hotel shelters in Victoria and Vancouver. People who are in those types of settings will have an increased access because they are instantly connected to a team. But the more disconnected you get, the less access you have to a service provider. Once again, the risk continues to rise for you. So a great deal of these access issues arise from the mitigation guidelines that were released by the BC Centre for Substance Use. This is not a slam on the BCCSU because the guidelines were never intended to be perfect, but they were meant to create a starting point so that we can continue to innovate and improve as we progress. The vagueness in the guidelines can make things really confusing, so I'm going to walk you through them, and hopefully in a way that makes you realize there's a lot we can all do to increase access to safe supply right here, right now. The eligibility criteria in order to meet the criteria to access safe supply is actually intentionally vague. It is so you are eligible if you are at risk for COVID-19 infection, or if you're confirmed positive, or if you're a suspected case. Anybody who uses illicit drugs, because anyone in BC right now is at risk for COVID-19 infection. So that's an immediate check for the eligibility. It's also for people who have a history of ongoing and active substance use. And it's for those who are deemed at high risk of withdrawal, overdose, craving, or any other harms related to drug use. So if you apply those three criteria to any of the clients that you work with, you'll see that for the most part, everybody would likely qualify, provided that they're actually using substances. Now, you have to actually do an assessment to make sure that they're eligible, and they want to make sure that you check off if they have an active substance use history. You want to make sure that you find out if they've had any previous overdoses. You want to take a look at any comorbid mental and physical conditions. What medications are they currently prescribed? And then the next step is to connect with a provider. And so what I did, so this actually, I'll back up a little bit. This document right here very concisely and effectively summarizes how one could access safe supply. This was produced by the BC Yukon Association of Drug War Survivors, and it was produced almost immediately after the risk mitigation guidelines had been released. But we've learned quite a bit since the mitigation guidelines have come out. And one of the things that we've learned is that accessing safe supply is the easiest for people who are already connected. And what that means is the more disconnected you are, the more high risk you'll be. So we've learned that asking someone who's at risk for overdose to self-advocate with their primary provider is actually incredibly traumatic to some. These guidelines that were originally put out there, they say, you know, it makes it sound like, hey, you're eligible, call your doctor, have a conversation with them, they'll write you a prescription and you'll be on safe supply. Easy peasy lemon squeezy. But it's actually difficult, lemon difficult, because what actually happens is this person has to call their provider, they have to call their prescriber and suddenly disclose that they're using illicit substances. You might have a relationship with your prescriber for the last 20 years and still been using illicit drugs, but now you have to be like, hey, Dr. Bob, I'm using this much fentanyl a day and I would like you to prescribe me some Dilaudid. And that did not go well for a lot of people who tried it. It resulted in them having their methadone or their Suboxone cut off. It resulted in a lot of harms. And it's very traumatizing for someone to have to go through that process and then be shut down by a prescriber. So we've learned from that. And based off of those learnings and through consultation with people who actually use drugs, I put together this service provider guide to safe supply access. This guide is not absolute. There will be other challenges that will require troubleshooting. And it's also important to note again that the risk mitigation guidelines are being revised as we speak. So this will have to be versioned as we go along. But essentially, I'm going to walk you through, you, the frontliner, want to help someone access safe supply. The first step that you're going to do is you're going to confirm their eligibility. Make sure that they are able to make sure that they check off those 3 boxes for eligibility criteria: at risk for COVID infection, using substances, and also at risk of overdose or withdrawal. You want to complete that assessment with them and really focus on substance use history, really focus on overdose history. People who had a recent overdose are prime candidates to get onto safe supply, and we should be advocating very strongly for them to get access to it. The next step is to keep it client-centered. Don't have any kind of assumptions in what your client needs, but ask them what they need. Ask them what they would prefer. That's a big thing that's missing from safe supply right now, is that we go through a history with a provider and the provider then goes, okay, I'll prescribe them this, this, and this. But nobody has taken the time to say, what do you need and how can I get you there? Then you want to try and connect to a prescriber. And this is arguably the most challenging piece. If you are lucky enough to already have a family doctor, that is always the starting point. So you want to call the family doctor, and you want to go through the history, remind them that the risk mitigation guidelines encourage people to prescribe during these high risk times. There is an updated phone number that was provided to me last night. So the version that's in the handout section of this website has a number different from the race line, and it's actually a medical consultation line that's available across British Columbia. So if your person doesn't have a family doctor, or the family doctor refuses to prescribe, you can contact that number and they can help you gain access to a different prescriber. It's also important to note and to remind prescribers that if they are unwilling to prescribe, they have an obligation to refer the patient on to a prescriber who will. It doesn't just stop there. They have an obligation to provide at least an option to speak with a prescriber who will prescribe Safe Supply. And that's really important to remind prescribers. It doesn't just stop with them. The next thing you want to do is walk alongside people. Like we said in the previous slide, don't just tell them to call. Offer to call with them, offer to accompany them to the appointment, be an advocate, because this is a really stressful time for people to have to try and self-advocate. Number 6 is likely the most important, at least to me, and that's to challenge the current guidelines. These guidelines are only guidelines. There are other drugs that are available that people will have more success with, that will feel more supported with. We have to make special considerations for people who smoke their drugs. And so if somebody is prescribing Dilaudid to someone who smokes their drugs, you want to remind them that that's not going to work. The next step is to liaise with pharmacy. It's really important that you set up with the pharmacy of choice of the client, and that you make sure that you try to advocate for medication delivery if it's possible. You make sure that there's no barriers to accessing it. Find a way to give them bus tickets if they can't get there. Whatever it is that you need to do in order to increase their likelihood of picking up their drugs or having it dispensed to them, we need to make sure that we try to do that. Some pharmacies are still not familiar with Safe Supply, and so if a doctor has prescribed and they've sent the script to a pharmacy that's new to you, then give them a follow-up call and make sure that they understand why they're doing that, and that they've had a chance to see the risk mitigation guidelines. The next is really critical too, and it doesn't happen enough, is to follow up. Create a plan with the client, find a way to follow up with them in less than a week to find out, is this working for you? Are you taking all of them? How are you using them? What can we do to make this work better for you? And lastly, start to develop a network. As you work with prescribers and you find out people who are willing to take on patients, as you work with prescribers and you find out who's willing to prescribe Safe Supply, keep a running list so that you know next time when you work with a client who you should call to gain access to Safe Supply. Now, this also is quite a bit of information, and I acknowledge that, but it is available for you in a handout form in a PDF so that you can review it as well at your leisure. They also, the BC Centre for Substance Use, have included regional contacts in their risk mitigation guidelines. This comes from the overview of the guidelines, and I believe it's the last page, but it's a very important page. And it has all of the different regional contacts where if you're not sure where you can direct someone to call to gain access to Safe Supply, this is always at least a great starting point for you. Sorry, were you going to say something, Sarah?
No, I just was finding the address for that document, hsa-bc.ca.
It's in the references for at the end of the PowerPoint as well. So then what else is there to talk about is the fact that we've acknowledged that this isn't really working, so we need some new and more effective models. And so we have some great models that are going to stretch and push the guidelines a bit more. Here in Victoria, we're working on that nurse peer-led model, and we started last week, and we got a couple people onto Safe Supply right away, which was really great. We set up peer follow-up, so they're going to visit them in the encampments and make sure that it's working for them. It's a good place to start. We also need to make sure that safe supply is available and accessible out of a public access harm reduction service. And so we're working on developing a model in Victoria where someone can come into a harm reduction site or an overdose prevention site, be assessed on the spot, and be provided with the safe supply to use right then and there, which is the most pragmatic and makes the most sense that we do something like that. If someone's going to come to a supervised consumption service to inject drugs that we know is contaminated with fentanyl, why don't we just provide them with something that's safer right then and there? I'm also working with a group from Moms Stop the Harm, and they're putting together a virtual doctor network where if people are in rural and remote areas and they don't have access to a prescriber, or there's only one prescriber and they're not willing to provide, you'll be able to log on to this website and visit a doctor through a virtual e-portal and gain access to a prescription right then and there. It's also early in its development, but it's very exciting to see that happen. We also have seen the increase of the MySafe project, and the MySafe project is the opioid vending machines that have been commonly known to be on the downtown east side. Those are starting to show up in Victoria as well, and they're likely going to show up in other parts, more densely populated parts of British Columbia. We're also working on access to diacetylmorphine, and there's a national group right now of advocates who are coming together to talk about what are the barriers and opportunities to have local national production of diacetylmorphine prescription medical heroin so that we can keep people safer and we can also provide the drugs that they will actually use. And last, there are whispers that nurse prescribing may be coming down the pipeline. And that's been something that I've personally been an advocate for quite some time. And it's very exciting that nurse prescribing may also be tied to safe supply as a means to remove some of that gatekeeping that's currently happening. Now, why is this taking so long? Well, unfortunately, our leaders continue to moralize substance use and overdose. Despite playing compassionate cards, we saw true colors from John Horgan last week when he told us that it's not fair to compare COVID with overdose because people aren't choosing to get COVID. That in itself was an incredibly telling statement because he's also a very progressive and forward-thinking politician, but unfortunately, he let it slip that he still believes that there is moral components to addiction and substance use. And that's likely why we've seen such a more comprehensive and supported response to COVID than we've seen for an overdose crisis that's been going on for 5 years now. Lastly, advocacy, my favorite thing to talk about. Following his little slip up, following Premier Horgan's slip up about moralizing substance use, he was quick to turn around and write a letter to Justin Trudeau and to say that he's encouraging the Prime Minister to decriminalize people who use drugs, to reduce the systemic stigma associated with illicit drug use and support people to access the services that they need. It was quite interesting that he put this letter out very shortly after he himself displayed some of the systemic stigma associated with illicit drug use. However, it's a good thing, and we need decriminalization. That is the next most important step in order to keep people safe. Criminalizing and punishing people who use drugs pushes them into isolation, which increases risk for death and many other harms related to overdose and other drug use related harms. So we're happy to see this, but we also have to acknowledge there's a lot more that a provincial government can do than write a letter. As well, there's a lot more that municipal governments can do than write letters. In Denver, they decriminalize substance use just by telling their police force to deprioritize arresting people who use drugs. And so there is more work to be done, but this is the year for change apparently, and we're really excited that some of this change may finally actually happen. Lots of information, and so I want to welcome any kind of questions and discussions from any of the attendees as well. Sarah, if you have any questions.
Yeah, I'm just sort of processing here. It's interesting to think about how much my unconscious bias around a moral understanding of illicit drug use plays into how I give care to people. And it's been a journey that I've been on for a long time. And it culminated recently in February with a loved one overdosing and passing away. And I mean, obviously, before that point, I had been much more progressive than I was growing up, but it really took a very tragic situation, a very heartbreaking situation, to make me really rethink some of the just internalized narratives I had about illicit drug use. So I just wanted to name that and say that there are things that we've been taught in our culture around drug use that are preventing people from getting help and staying alive. And I'm really glad that, Corey, you've put this together today, and I think it's part of our advocacy, as well as really pushing to make these systems, as you said, not just tied to the pandemic, but ongoing as a way to save people's lives and to help them get to a place where they're stable. So
I
there's
have a shirt.
Yeah.
I'll tell you my story, and then I have a shirt, and it's from the DARE program in the 90s, and I think it still exists in some way, shape, or form, that a friend of mine gave me. And she lives in Alberta, and she lost her son to overdose about 3 years ago. And now she works with Moms Stop the Harm to help develop more supportive and evidence-based drug policy in Alberta so that other mothers don't lose their children. And she gave me this t-shirt, ironically, because we always used to talk about the DARE program. And the DARE program for me is the most perfect exemplification of what's wrong with our current train of thoughts when it comes to drugs. This was, for those of you who are unaware, the DARE program is a group, a subset of police officers, I think it's RCMP, and they come into schools and they teach kids about the ills of drug use. And they tell you, if you use these drugs, you will die. And I remember one police officer asked us all at the start, what's the biggest gang in the world? And all of the kids were like, Yakuza, Hell's Angels. And he was like, wrong, it's the police. And it was meant to kind of like make police cool and drugs bad, you know. And they show you that egg and they're like, this is your brain, and then they crack it and scramble it and they're like, this is your brain on drugs. And that is where a lot of our mindset around substance use comes from, about misguided images about people who use methamphetamines, about media and how every time there's an article about substance use or overdose, they use a stock photo of like 2 needles in a puddle in the downtown east side. And all they're doing when they're doing these things is they're reinforcing the belief that illicit substance use is bad, therefore people who use illicit substances is also bad, and it becomes ingrained in our minds. But the truth is that the DARE program was most prominent at the time when I was in high school. And I'm age 32, I'm in the category, the subset of people aged 30 to 39. And now the leading cause of death in Canada for people aged 30 to 39 is overdose death. So if that doesn't tell you that we've been looking at drug use and we've been educating about drug use wrong, I don't know what will.
Yeah. So there's a question here, I love this question, around what would you say to an organization or an agency that wants to implement safe supply when they haven't done so before, and especially if there is apprehension about harm reduction in general? So, you know, I mean, you might be the person at your workplace who thinks, wow, this is a great idea. I really understand this. I think it will really help people. But what's the next step if you're in an organization or an agency that is still apprehensive and not really well versed in harm reduction at all, even as a philosophy?
Yeah, I mean, and it's really unfortunate that there are still organizations that will abide to that belief that there, pardon me, that there is still so much aversion to harm reduction. So I always encourage people, like, no matter where you're at in your workplace, you have opportunities to advocate. Harm reduction is evidence-based, and safe supply in itself is one branch of harm reduction. Show them the evidence. There is a study that I also shared with Sarah that'll hopefully go up on the hsa-bc website, but it's a study from a group of researchers in the downtown east side called Tackling the Overdose Crisis, the Role of Safe Supply. And so we really need to tell people that now is not the time to rest on ideological laurels. If this is an evidence-based service, then we have an obligation to be doing it. Now, it's easier to say that than it is to actually approach your place of work and come with that kind of mentality. And so you might have to be more subtle in the way that you're educating, but harm reduction belongs in every workplace setting. Everywhere that care is provided, whether it's care specifically for people who use drugs, or care for people in hospitals, or care for people in long-term care facilities, harm reduction in itself belongs there, because it's not just an array of services, it's an underpinning philosophy for how we support people. It's about understanding what your actual needs are by finding out what people want and prioritizing those needs in a client-centered way by not applying judgment. And I'm pretty sure we can get behind that in its broadest sense. Now, what's also going to need to happen in order for these organizations to get more on board is that the government and the guidelines that are available are going to have to be more robust. They're going to have to be more detailed. The current risk mitigation guidelines scare the shit out of some people because they're so vague. When they first came out, just looking at that eligibility criteria, it was like people at risk of COVID-19, people at risk of overdose, and people who use drugs. And we had some doctors who were like, well, I'm only going to prescribe this if someone needs to isolate because they got a COVID swab. And then we had some doctors that were like, no, everybody is eligible because everyone's at risk of COVID. That kind of inconsistency is really detrimental because you're leaving too much up to interpretation, and the language needs to be much clearer that this is the people who qualify, that they should be offered access to it. And so I think when the guidelines become more robust and when they are more supportive of prescribers and pharmacists, then you'll actually see more buy-in from organizations as well.
Yeah, but in the meantime, having a copy of those risk mitigation guidelines to start to talk to management about, and having those, even, some of the handouts from today as evidence, as a place to start discussing this.
Yeah, for sure. I was working in one of the clinics last week, and we got a fax from a pharmacy, and it was said, "Dear Dr. So-and-so, I am writing to express my concern about the daily dispensing of Dilaudid for patient X. I am worried that this will increase risk. I am worried that they are not going to take them as indicated because everybody writes their prescription for ingestion, which is by eating, but they know that people are injecting it. And so it was a little scary to that pharmacist. And they said, I would not be willing to dispense this to this individual at this point in time." And the doctor very playfully wrote back, "Please review the risk mitigation guidelines, and after you've reviewed them, we can talk." But I followed up and had a phone call with them, and we ended up having like an hour-long education session and went through the risk mitigation guidelines together, explained what the actual intent and purpose was of Safe Supply. And by the end, the pharmacist was like, "This makes total sense. I'm really sorry. This is new to me, and I didn't know what my liabilities were, and it just scared me a little bit." And after we talked about it, they agreed to do the daily dispensing. And so it takes a lot of groundwork. It's a daily grind. But every time we get one of those victories under our belt, we've increased accessibility for multiple people.
Yeah, and if you start to talk to if you start to collect pharmacists and doctors who are actually open to and willing to support you, then you're starting to build that network, which means you can send more clients to them as well. So I've got a couple more questions here for you, Corey.
For sure.
There's a question around someone who's in a very small town in the north of BC, who works with a lot of individuals suffering from addiction, and they're wondering how this system is set up. Is it province-wide? Like, are these guidelines a province-wide thing? You know, how does this apply in a small town?
Absolutely. So the first answer is yes, this is a provincial mitigation guidelines. The province itself has created exemptions so that these drugs can be distributed and that they can be prescribed for people who are at risk for overdose. And then the other answer is really poorly. It's really poorly set up for people in rural and remote areas. And so there's a number of potential concerns ranging from getting someone actual access to the meds. Is there a pharmacy that they can access locally? And that is something that requires quite a bit of troubleshooting. And then it's about getting a prescriber on board. And when you're in small town and you're in rural, remote areas, there might be one or two prescribers. And if they both say, I don't believe in safe supply, you feel like you're in a bit of a hot spot. So my recommendation again is if you reach out to those prescribers first and foremost, and they say that you request the name of an alternative provider who will prescribe it, because there is a moral and ethical obligation that they cannot simply just turn aside care that's being directed by the province, that they actually have to, if they're not going to do it, they have to provide somebody else who will. And if that doesn't work, then I would try calling the phone number that's on the infographic that I've provided called Safe Supply Access. And that is a 24-hour or it's an extended access clinician phone line that is available across the province. And it's supposed to get you access to a prescriber in your local area. And then, so what would be really great is if you think this is something that you want to do, is to start by developing that network. So reach out to the prescribers that you know, reach out to the pharmacies that are local, and try to bring them together and talk about how you could actually safely roll this out. I did it in the complete opposite end when this first came out, and it definitely was disjointed. But when Safe Supply was first announced and the mitigation guidelines came out, I just started calling doctors and being like, I have this patient here. And it was definitely labor intensive. And in hindsight, what we should have done was that we should have brought together a whole group of physicians right away, found out who was on board, create that network, and then a system so that we could contact them and get people access when they need it. So a lot of this, like I said, has been iterative. You just get started and try to work your way through the guidelines and develop that network. And then when something doesn't work, you have to problem solve and troubleshoot and find the next angle.
Yeah, it's a lot of work up front.
Especially when it's rural and remote.
Yeah.
Like I can't tell you the number of people who have contacted me, and even like in the interior, what they've shown from the coroner's data was released. They also had a little excerpt from the Safe Supply data. And one of the things that they highlighted was there was around 1,700 people currently in British Columbia on Safe Supply, which is a fraction of the 20,000 people who are at risk of overdose on a daily basis, and that almost all of them were in the downtown east side and supported at Vancouver Coastal Health. So I think 350 is Victoria, where I'm at, and then the rest almost exclusively are in Vancouver Coastal Health region, with some in Fraser Health, but it gets hugely disparate as soon as you go into the interior or into the north.
Mm-hmm. The folk who are working in small towns, we just admire you. So more questions coming in here. This is great. Can you talk about meth users? And because a lot of what we've kind of given as example are people who use opiates or alcohol users, but with methamphetamines, the risk of, oh yeah, let's put ourselves on video here. The risk of overdose is somewhat less, but so many of the other benefits from Safe Supply still apply. Hello, everyone. So this person is saying that there are less options for meth users, whether for harm reduction or addiction treatment. Do you want to talk a little bit about that, Corey?
Yeah, that person's 100% right. The stimulant replacement that's available from the risk mitigation guidelines People don't even like that. Like when people who are using methamphetamines, I've gotten a few of them onto Safe Supply, which is either Ritalin or Dexedrine, which for those of you playing at home, those are ADHD medications that are very similar to amphetamines, just a couple chemical chains away from being what people are taking on the streets, minus all of the buff and substrates that go into it that increase people's risk. But there's problems because the types of drugs that are available aren't what people want. To be able to smoke them, which a lot of people smoke their meth. That's not how those drugs really work very well. And then the dosing is horribly inadequate. So the amount that they suggest in the guidelines just pales in comparison to the amount that people are using on the streets. So again, that's a call for us to continue to push back on the guidelines so that they can provide an alternative substance that's more comparable to what people are currently taking, because you're absolutely right. People who use stimulants on the street are at risk for overdose. They're at risk of other harms related to the illicit drug market, and they are still prime candidates for Safe Supply. If anything, this has just told us that the guidelines haven't gone far enough yet, and we need to keep pushing back on it. We still do, like even though we know this about stimulant Safe Supply, we still support people when they want to get access to it, and we work with them because part of the project that we're doing right now is that we follow up with them afterwards and we ask them like what's working and what's not working with this prescription, and we can get data on why this current version of Safe Supply is not effective for them, so that we can help guide decision makers to provide better alternatives.
Mm-hmm. Good. I hope that was helpful. I think it was. So then there's a question around how do you encourage your clients to follow through on accessing Safe Supply, especially if their previous experience hasn't been ideal, right? Because we're kind of in a testing, there's a lot of barriers and things aren't predictable. So talk to me a little bit about your experience there.
Yeah, I mean, you got to find out why it wasn't successful for them. And so this has again been a really iterative process, because we go back to people and we find out that they never came and picked up their prescription, and so their prescription got cut off. We go back to people and ask them like what was going on, and we realize that we make a lot of assumptions when we set it up. In my head early on with Safe Supply, all I was thinking was like, get that script and get the meds to them, and that was the be all end all. And we realized that that's really short-sighted. That there's so much other work that needs to be done, because there's a lot of reasons why people won't go and pick it up. We had someone who didn't pick up their Safe Supply prescription twice because the doctor just immediately sent the prescription to a pharmacy that they knew and were comfortable with. But then we found out from that person that they won't go into that area of town because there's some bad blood between them and some other people who are around there. And so we made these assumptions, and then we realized, okay, we need to work with people to find out, what pharmacy do you want? Do you need the medications delivered to you? Will you be able to pick it up in the morning or the afternoon? And we have to check all of those different boxes to make sure that this is actually accessible to that person, and know that accessibility means a lot of different things to a lot of different people. And so you really, you have to individualize your approach when it comes to Safe Supply. It's not just get them access to the prescription and make the assumption that all is well after that. Sometimes people won't go and pick up because when they go and use for the first time, it's not an adequate dose, and they start to go through withdrawal, and they're like, screw this. So we have to go back to them and then contact the prescriber and say this isn't working for these reasons, and try to make sure that we're having that back and forth process, that we're constantly working on finding better ways to make this happen.
Mm-hmm. And it's interesting to think about how we kind of, or at least I often came from the perspective that you don't really question a doctor, and they have a process that they just do, like they're the expert, right? But even in my own situation, I've had a lot of success with saying to my family doctor, hey, can you send this to this pharmacy? Because it's a 5-minute walk from my house. And it's way easier for me to get there than it is to go just, because people have systems and it's automatic, right? But if you can kind of really be specific and say, look, I know you might have a system about what pharmacy you usually use, but here's the one you need to send this to, and then follow up on that. It's can make a big difference.
And as frontline workers, that's part of our job, is to be advocates in those conversations, because a lot of people who use drugs are used to a very paternalistic system of care when it comes to receiving addictions medicine or just hospital care. And so they, of anyone, often aren't comfortable saying that's not going to work for me. They're just happy that someone said, yeah, we'll prescribe it to you, and don't even know that it's within their rights to say, like they're the experts in this situation. And I am very fortunate to be working with the group of doctors that I am, because they acknowledge first and foremost that they are not the experts in this situation, and they want to hear more from people who use drugs, and they want to break the system down a little bit more, so that it's more accessible. But that's not always the case. There are still situations where you're going to encounter a prescriber who finds any kind of disagreement as challenging. And you need to really work on relationships with providers and prescribers so that this is a work in progress for all of us.
On that note, we all know the state of finding a family doctor in BC. In Vernon, for example, I think there's only one practicing family doctor, and I had the poor experience of getting ill when I was up there last year and then needing to go to a clinic, and I sat there for 4 hours because the whole town uses the clinic. So do you have any advice? Well, maybe you don't, but I just want to acknowledge that it is actually very difficult to find a family doctor in BC, even if you are not outside of the system.
Yeah, I still don't have a family doctor in Victoria.
Yeah.
So the wait list is like a year and a half or something like that. This has been a tremendous challenge for all of British Columbia, that there's always been a poor per capita ratio of physicians to the general population, and especially during the times of COVID and a pandemic. Lots of doctors aren't taking new patients because they can't do consults in person, and they always want to do their initial consults in person. And so for the interim, making use of those 24-hour clinician lines to at least be connected to someone. They may not accept that individual as their patient, but they will still provide some continuum of care during this time. There are also, for folks who are using drugs, usually there are opioid agonist therapy clinics, especially in urban areas, where doctors are accepting patients. So I would try there as well. But whoever asked that question, just tapped onto the age-old issue in British Columbia of really, really difficult times trying to get a prescriber. And I wish it wasn't that way. I was fortunate enough to get my children a doctor, but I'm still on 3 waiting lists myself, so I can empathize with people for sure.
Have you had any experience with walk-in clinic doctors and Safe Supply?
No, because we have a different system in Victoria. We have a group that's called Canico, which is Kool-Aid Mobile Inner City Outreach, and they created a network of 24 doctors who cover all of the hotels, and then one doctor covers the arena, which is another temporary shelter site, as well as outreach sites like in the parks. And so if the individual has a family doctor, we go there first. But if they don't, I have a number that I can call, and it'll direct me to the on-call physician for that day. And they won't take the person on as a patient, but they will facilitate access to Safe Supply.
So potentially, a doctor at a walk-in clinic who is amenable to harm reduction, there's nothing barring them from prescribing.
Absolutely not.
Yeah. Okay.
Nurse practitioners can prescribe Safe Supply as well. So, I know I work with a couple of NPs in Vancouver who are actively prescribing Safe Supply, but they're even more tightly regulated than physicians. They have even more oversight and people questioning their decisions. So it's, again, speaks to the need to broaden out access. If we actually see RN prescribing, what will likely happen will be RNs will have to take a special course through the BC Centre on Substance Use to certify themselves. And then we might actually see some real traction gained, especially in
Mm.
rural and remote areas, because nursing access is definitely higher than physician access.
Mm-hmm. And so there's a question here around, once you get access to safe supply for an individual, um, where could you give that feedback on how it's going? We've been talking a little bit about how advocacy and um, data is important. So do you have some connections for frontline workers who are trying this out and seeing success?
Yeah, I mean, right now they're in the midst of a massive review and they're actually seeking out feedback related to it. I think you can find the email address at the BCCSU website. But one of the people, when I put out that Safe Supply Access PDF, who contacted me, said, "Hey, this is really great. I'm on the permanent review board for the Safe Supply guidelines. Can I make use of this?" And I was like, "Oh, that's both reassuring and scary." But they're obviously, very cognizant of the challenges of the current guidelines and the need to change them as well. Because I explicitly say in that infographic to challenge the guidelines and to push them outside of their boundaries. And even the people who are reviewing it are saying that they agree with it and want to make use of it. So I would contact the BCCSU because they are the authors of the guidelines. Yeah.
Okay, that's good. And actually, we're kind of coming to the end of our time now, so that's a good place to end, I think, unless there are any more pressing questions.
No, I'll just, do I still have control here?
Yes, I'll stop. Yeah, go ahead.
Quit touching things. Yeah, here's just a number of resources that are available, and I always believe in showing your work, so here's my list of references for today. And of course, if anybody wants to chat, you can email me at Corey@westsideharmreduction.com, or of course you can contact Sarah and hsa-bc. Please send questions. Please do the follow-up survey so that we can find out what else we need to provide in terms of education so that we can better support you. And thank you again, everyone, for being here today and for taking the time. I hope that it was useful to you.
I really appreciate you putting this together, Corey, as well as all the work that you're doing to make it happen in your community. It's inspiring and it's helpful to hear your experiences. So I'm hoping that we run this again, and the next time we do, maybe we'll have more info. But do, as Corey said, do get in touch with us. Do get in touch with him. We love it when we get to hear more from you about how it's going or what you need. In September, we'll be having our annual conference, but this will be online this year as everything is going this way due to COVID. So you can find everything out about that conference on our website. Corey will be presenting there as well as many of our instructors. I believe Dr. Danielle Ben-Smith is our keynote speaker for that event. As well as a couple of other folks. So please take a look at that. You can find the schedule, you can register and do all of that there. And as always, here's how to get in touch with us. Give us a call, send us an email, check out our website, especially under the Sector Resources tab. Corey referenced a lot of handouts and things that are there, pardon me, for you to download. So thank you for being here. I'm just blown away by how 100% of our attendees today are frontline and outreach workers. And I am in awe of what you do every day. I have been in this industry, this sector for a long time, and the work you do is so essential. So thank you for continuing to show up. Even in these uncertain and challenging times, you show up for people every day, and that's just incredible. So take care, everyone, and we'll see you in August. But in the meantime, if you want to get in touch with us, please do, and fill out that survey so we know how to keep going with this. All right. Have a good month, everyone. Take care.